Alright, so this is going to be part 2 of the C-spine. It didn't quite fit all the way on that one 15-minute section, so we have another section for this, which hopefully shouldn't be as long. If you want to know if you've got a good AP axial view, you really should have C3 through C7 on there. If you look at this one, we've got down to T1, T2, T3, T4, so it's a little bit long in terms of how far inferior it should be. We really should end it probably right about the level at the top of the clavicles. You notice where the clavicles are, those usually sit between 2, 3, anywhere between 2 and 4 on most patients. So if you get the heads of the clavicles on there at the superior edge, you should have C7 going all the way up pretty well. If the light superiorly is hitting the chin, that's about as much as you need to get on there. A good C-spine will have, on the axial view, it will have the gonions or angle of the mandible on there. It won't be too high, it won't be too low on there. You should just see this, the edges of it here. Now you see this flat part going across right through here. This flat line here means that the chin should have been raised up just a little bit more, or you can sometimes use a 20-degree angle on that. What you want to do is just raise the chin up just enough, just so that you can see the points of the mandible on there. Okay? If the skull looks pretty round, which you can see a very faint roundness going across here, this is the occipital bone, or the back portion of the skull. If that is going over the vertebra, then your head is too high and you need to raise or bring the chin down just a little bit. PA obliques. PA obliques are preferred as opposed to the AP obliques, simply because of the thyroid dose involved. The thyroid dose for PA obliques is about 1/10 the amount of radiation as it is for the AP obliques. So your CIs will show you how to do AP obliques, but eventually you should probably transition more to PA obliques just for the sake of the patient's health and driving the dose down as much as possible, because there are some patients that have a little bit more sensitivity to their thyroid for whatever reason, so we want to avoid giving them an extra shot of radiation if at all possible. The area of interest on this particular view are going to be the intervertebral foramina. Intervertebral foramina are going to be these little holes that are going through the posterior portion of the neck. Now do not confuse these little holes with the transverse foramen. These holes are created by basically the stacking of one vertebra on top of the other. So there's a little semicircular portion on the inferior portion of the vertebra, and there's a little semicircular portion down here that's going to create this illusion of this hole coming through here. And this hole is created by two vertebrae stacked on top of each other. Minimum distance will be 40 inches. You can do these at 72 inches as well. 8 by 10 cassettes, so small cassette sizes for pretty much everything. We're going to do this on expiration because we want the shoulders here to come down inferiorly as much as possible. The Merrill's book talks about the suspended respiration not only on this view but on the lateral view, which is more incorrect than anything else. We want to bring those shoulders down as much as possible. Chin up, so the chin needs to be partially up. The body is going to be about a 45-degree angle. So that means that you're going to stand in a true oblique to the upright bucky. CR is going to be about C4. We'll show you how to isolate that so you can see that a little bit better. Tube is going to be angled 15 degrees caudad if you were doing PA obliques. So if you were doing AP obliques, that angle is going to change to cephalad instead. Okay? But for the focus of this class, we will be angling the tube down towards the feet. Do these erect if possible. If your patient cannot stand, the second option is to sit them in a stool and then just kind of roll them up to the bucky. We can do these supine on a table for certain trauma views, but they don't come out quite as nicely, so better to get the patient upright if at all possible. AP obliques, basically the same as PA with some exceptions. This is going to be a 15-degree tube angle going up. It's going to show you the exact same image because the neck is basically in the middle of the body, whether you do it anterior or posterior. They're going to have higher thyroid and breast doses with these obliques. Simply because of the scatter when the patient is facing out towards the tube, we'll just give a little bit more of a dose. Not a lot, but a little bit more dose than if you were doing it PA. What you're going to look at is you're going to look for the foramina going down each way. We are going to see that foramina on both sides of the neck, so we do need to do these bilaterally. That means you're going to do one RAO, one LAO, or one LPO, and one RPO on there. You need to want to make sure that the pedicles are in the anterior portion of the vertebral body. So as you look at this little kind of squared portion here, the pedicles, These little round sections should be in the anterior portions of that. They should not be too far back, or they should not be outside of that where it's going past the edge of the anterior body on there. You're going to see the little struts going across here. You've got one pedicle here, which means the other pedicle is going to show up right through here. So you're not going to see both pedicles, but they are going to look different because they are on opposite sides of the spine now. So another one on the PA obliques. You should adjust this so that the long axis is going to the long axis of the neck here. So this should not be straight up and down because we cannot cone adequately for that. This one should have been coned down a little bit top to bottom. We don't need any of this down in here. We're looking simply at these intervertebral foramina going all the way up through here. So you should see, you're not going to see one between C1 and C2, but you should see C2, C3, C3, 4, 4, 5, 5, 6, 6, 7. And you can see this one here between C7 and T1. But anything below that kind of shifts in anatomy. They don't have transverse foramens anymore, so it's going to look a little bit different from the C-spine to the T-spine. Show a little bit of anatomy marked on there as well, so you can see which we were talking about. Swimmer's lateral. If all 7 vertebrae are not seen, this is a view that you must do. If you do your laterals correctly, you are not going to need to do this view very often, but on patients with bigger shoulders or have been in car accidents and their muscles are tensing up, you will have to do this view. This is probably the most common secondary view outside of the 5 we've already covered. You're going to use about a 3 to 5 degree caudal angulation instead of a perpendicular CR, so you're going to angle down towards the feet a little bit just to move some of the clavicles a little bit more so we can see that C7 vertebra. CR is going to be about T1. You're going to see a variety of texts position this a little bit differently. You don't have to center right on T1, but you do need to make sure that you get this area down here so that we can see the entire body of C7 plus the top of T1. It's going to be done on expiration, erect, obviously much easier than to do it on the table, but it can be done effectively on the table, especially when we get into the T-spines. Fuchs or Judd. This is to demonstrate the tip of the odontoid process. So if you do not get the tip of the odontoid process, which you see here on your regular odontoid view, either because the patient can't open their mouth very much or their anatomy just precludes you from actually seeing it all, then you should do this view. This is going to be done at 40 inches. We're going to CR is just going to be just below the chin on this one. Suspended respiration. You can angle the tube 15 degrees cephalic, so up towards the head if you're doing the AP Fuchs method. So it's going to look very similar to the AP axial view that we talked about earlier. You can use a 0 angle, but the mento-meatal line has to be perpendicular for the Judd method. And we'll show you the mento-meatal line in class. You have to raise the chin up pretty high up, though, to be able to get that with a 0 angle. Judd has less thyroid dose, but not much, so it doesn't matter whether you do the AP Fuchs or the PA Judd. Tight collimation, not this. This is horrible collimation. We only really need to see this area down in here for the Fuchs. You can do this supine or erect. Some techs have a little bit more easier time to do this supine, but it's obviously going to decrease efficiency if you're doing some of them standing and then some of them lying down. Some pathology. You see a little teardrop fracture right through here, so a little bit of the vertebral body. You can see this little break right through C2. Traumatic event caused by a fracture of C2 on the anterior surface, normally associated with spinal cord injuries. Because the spinal cord does run right in between this, if you have any types of fractures, it can affect the spinal cord. Normally, unstable, associated with severe ligamentous injury and loss of stature of the anterior aspect of the vertebral body. So it's not going to be in line with that contour line that we talked about earlier. Burst fracture. C7, so lateral view of the C-spine demonstrates coming into vertical fracture, so you can see that it's no longer square down here. It looks kind of wedge-shaped going across in there. There's a little fracture just behind here, probably on the pedicle, most of it. Hangman's fracture, severe trauma resulting in break of the arch, usually at the pedicles or the pars. You can see the fracture, one right through here. Looks like another fracture through this area here. C2 fracture in most cases. This is seen in motor vehicle accidents and occasionally sports-related injuries. Hyperextension may cause this injury. Sometimes the snapping of the neck going forward will cause that type of fracture as well. It's called a hangman's fracture because this is typically what breaks. In the old days when they used to hang people, the neck would actually break and then cause spinal cord damage. Jefferson fracture is a bone fracture occurring at the first vertebra, classically described as a 4-part break. Fractures the anterior and posterior arches of the vertebra. They also appear as a 2 or 3-part fracture as well. So with this one, what you'll see is that the edges of the vertebral body will not be lined up. You can see the edge of this pretty much vertebral body or lateral mass is not lined up here with this portion out here. So it looks like it's on both sides that it's not lining up. So you can't see it as well as you can see on CT, where you would actually see these breaks going through. Either that's a 3-part fracture there, or this one with a 4-part fracture. Obviously, it's not going to be connected to C1 very well, to C2, so very unstable, can cause paralysis as well. Spinous process fractures C4, 5, and 6. You can see these pretty well, these little black lines through here. These can occur at any level, but usually the smaller vertebra, depending on the hyperextension, can cause these fractures, and these vertebrae a little bit more commonly. Clay shoveler's fracture of C7 down here. If you look at the spinous process, it's broken across on here. This doesn't really affect the spinal cord because it's tucked in this area a little bit more, but still, if you can avoid breaking anything, then try to avoid breaking your neck. Here, see little studs for earrings that were not taken off. You can see their relative location in relation to C1 on there. That's why the earrings do need to come off. Occipital fracture dislocations are also common. This is called orthopedic or internal decapitation. It's mainly from severe head trauma. Skull separates from the spinal column in this case, so obviously it's going to be fatal in most cases because of nerve damage and the severance of the spinal cord. There's only been, I think, one reported incident where a patient had this occipital fracture and they actually survived without paralysis, but very uncommon. Usually this results in instant death. Dislocation of vertebra, you see that they're not quite lined up, contour lines are lost. It may cause paralysis because the spinal cord is running basically through this area right through here. So if you get this vertebra that's dislocated, it can definitely sever that part of the spinal cord on there. Sometimes they can do traction, pop this vertebra back in place slowly so that the spinal cord does not become damaged. Treatment, this just goes into a little bit of treatment on there. Hopefully I'll find the link that you can look at on this, but basically if you have the vertebral body in the front with some erosions on it, they can go in, they can remove this disc, sand it down or surface with some type of scraping device. You see if you have this type of problem that this yellow part right here is the nerve, and this is where the intervertebral foramina is. So if there's erosions here, it's going to definitely affect the foramina. So we have to go in there, build that back up, a couple different plates, and then that takes pressure off the nerve. It causes some radiculopathy through the arms. Prosthetic device, C5, 6, and 7. You see those little kind of spacers in there. Don't be afraid, they do not swallow that. That is actually inside the neck on the vertebral bodies. Fusion, they can obviously fuse part of the neck together to kind of take pressure off that so it doesn't collapse upon the disc space below it. Prosthetic device, this just shows a couple different things that they do. They can put screws in and kind of lock these in place so that at least one portion of the vertebra is a little bit more stable than the rest. Answer to the earlier question, the giraffe has 7 cervical vertebrae, same as in humans. What's interesting about this though is that these 7 cervical vertebrae are about 11 to 12 inches long, so a lot of length in that compared to the 1 to 1.5 inches of a normal human spine on there. So a little bit of trivia on there. Not all that different. If you look at some of the other bones, there obviously are going to be different. There are no tails on people, obviously. You can see the ribs, though. The thoracic spine has some spinous processes on the back there. There's a little bit more upright going across on that. So this concludes the cervical vertebra presentation. There are other views to cover, but we will be going over quite a bit in the laboratory. If you have questions about this or how your clinic may be doing AP obliques as opposed to PA obliques, we can certainly cover that as well within the labs.